this stuff, what you've learned. So, with this being said, I do this presentation to all the clients in the treatment center, and I gave it to Julie, and she's like, "You got to do this for the ICAK." So that's basically this is where we're at right now. So, okay, so. With this being said, I'm going to start off with a little quote. I'm not going to read the whole quote, but cannabis isn't a gateway drug, alcohol isn't a gateway drug, nicotine isn't a gateway drug, caffeine isn't a gateway drug, trauma is the gateway. This is a huge thing, and basically, what I'm going to talk about is polyvagal theory. So, when Dr. Bandy told me to read this book, anytime anybody tells me to read a book, instantly, I'm on it. So I love reading, and I read the polyvagal theory. And how many of you guys have read the polyvagal theory? How many of you understand the polyvagal theory? So, notice how many fewer hands went up after? So, I read the polyvagal theory, and I said, okay, all right, once I read this about 10 more times, I think I'll get it. And so, luckily for me, he's put out a bunch of different books, and so now I think I've legitimately read one of his books at least 10 times. But what I'm going to try to do today is basically summarize the polyvagal theory in a very short period of time for you, so you guys can kind of get an idea of how what we're doing, what's happening in the body when we're doing what we're doing. So, Polyvagal Theory is a book that was released in 2011. It started off in 1983 when Dr. Porges wrote an article called Heart Rate Patterns in Neonates, a Potential Diagnostic Window to the Brain. So, what ended up happening with this is he basically went into the neonatal intensive care unit, and he looked at babies, and he wanted to figure out how can we tell which babies are at risk of dying and which ones are not, which ones are safe. And what he found was that something called RSA, respiratory sinus arrhythmia, which is increases and decreases in your heart rate as we breathe. We know HRV, right? So heart rate variability is a measurement of health. And so he writes this paper, and he says, activation of the vagus nerve causes increases in RSA, and therefore it's a sign of health and robust health. And so he gets an article back, or he gets a letter back. His article is well received. He gets a letter back from a neonatologist who says, "That's a great article, but everything I learned in school tells me that activation of the vagus nerve causes death in babies. Isn't that funny? I guess too much of a good thing must be a bad thing." And so as a physiologist, he's like, that doesn't make any sense. How can something that helps you also kill you? And that's what led to what he called the vagal paradox. And the vagal paradox is, how can activation of the vagus nerve both create robust health and cause death? And so what that led him to understand is that the vagus nerve is not one nerve really. It's actually two different portions of the same nerve. And notice I say ventral vagal complex and dorsal vagal complex. It's not just the vagus nerve. There's other areas and other nuclei around these areas that act in synchronous, like they help aid the function of these nerves. So what I'm going to do now is basically kind of just summarize, with this being said, he ends up with this article, and he ends up writing this book. He figures out the polyvagal theory, and then a trauma therapist, a PhD psychologist, ends up reading his work and says, "Oh my gosh, this explains what we are experiencing, what trauma survivors are experiencing." So polyvagal theory got picked up by the whole psychology profession, and it gets used to explain the whole what happens in the body when we experience trauma. So what I'm going to do is basically try to explain this for you. So this is Stephen Porges, and so what does Stephen Porges have to say about the future of trauma therapy? It is clearly going more body-oriented. We now have talk therapists and psychologists using body-oriented treatments and stuff that we've been doing since the beginning of applied kinesiology. They're using this stuff. And so what I'm going to do is show you one of the techniques that I'm doing, but I'm going to also kind of show you a lot of what Dr. Bandy showed last time. So ultimately, what we're talking about is safety. Everything that drives us is safety. And so, deficits in feeling safe form the core biobehavioral features that lead to mental and physical illness. So, what I'm going to do is try to summarize these 6 books in about 50 minutes. So, wish me luck. So, all right. So, but with this being said, let's start off with this: sympathetic versus parasympathetic. This is the way we've always been taught. The way this works. So we all know fight, flight, and freeze, right? So here's my question for you guys: who thinks is fight or flight? Is this sympathetic or parasympathetic? It's sympathetic, right? How about freeze? Is that sympathetic or parasympathetic? Interestingly enough, freeze is parasympathetic. It's 100% parasympathetic, right? The true freeze reaction. But let's understand how this works. So, since the time of Galen, in 129 AD, we've always thought that the sympathetic nervous system functions antagonistically to the parasympathetic nervous system. This is not how it works. This book is revolutionary because it really changes the way we've been thinking about the autonomic nervous system for the last 2,000 years. So, when we hear all the everybody talking about we need to increase that vagal tone, that'll kill you. I mean, that's how you die, right? So I'm going to spend the next few slides here. I'm going to try to explain the functions of these different parts. So I keep hitting the wrong button, sorry. All right, so a better analogy is going to be the way I like to explain this to people is rather than talking about a teeter-totter where you're either in high sympathetic tone and low parasympathetic or high parasympathetic and low sympathetic, I think of it like a car. Think of your autonomic nervous system like a car. You've got your, anybody ever have a car that's just tuned a little bit too high? The second you take that foot off the brake, it lurches forward. That governor is going to be your ventral vagus. That's the thing that kind of starts to slow us down. And now your gas is going to be your sympathetic nervous system. That's just mobilization of energy, right? And your dorsal vagus is going to be your emergency brake. So what can happen in some people is their emergency brake is pulled on, and they're driving around with, RPMs are at 9,000, and they're going 30 miles an hour, and they're anxious all the time, and they've got a high heart rate, and they, GI issues and all kinds of stuff. And so, understanding the way these all work is going to help us understand why what we're doing works. So like I said, parasympathetic creates inhibition, and it can work its way all the way into the freeze response. So the social engagement system is going to be, our ventral vagus is also known as our social engagement system. So this is going to be what expresses and detects the features of safety. So this is our ability to look at somebody and say, this person's safe. This person gives me the sense of safe. Right? Interestingly, don't forget that 80% of the function of the vagus nerve is sensory. So a lot of that function that we get is taking in information from other people, right? And there's a lot of subconscious, if you want to call it, input that we get. And we're going to talk more about this as it goes, but our dorsal vagus is going to be thought of as our passive defense system. This is going to be kind of like, this is our shutdown system. When we talk about the freeze response, it's the dorsal vagus. So the ventral vagus is going to, it originates at the nucleus ambiguus. It's the myelinated portion. It's the smart vagus, primarily controls supradiaphragmatic organs, stuff above the diaphragm, right? And then so this is the part of our body that creates heart rate variability. And the way it does it is through suppression of heart rate at the SA node. So I remember Mark Allen saying, if you were to cut that vagus nerve at the SA node, what do you guys think would happen to our heart rate? Would it go up or would it go down? Who thinks up? Who thinks down? It would go up. This is that governor, right? So our resting heart rate should be around 90 beats per minute, but it's due to vagal control that calms down that heart rate and makes it so that we only have a heart rate around 60, right? So that's that. So we need that governance. So I'm going to keep painting a picture here. That social engagement system, that feeling of safety, is what allows us to have a lower heart rate, to feel safe, to feel calm, right? So, when you look at somebody and you see their heart rate increase, all it takes is for them to feel a little bit disconnected from somebody, a little bit afraid. They don't have to have a big surge of their sympathetic nervous system isn't necessarily firing to see an increase in heart rate. All they have to do is just feel a little bit unsafe. So, all right, so the next part of this, so the way heart rate variability is created is as we breathe in, we see activation of we see a decrease in activation of the vagus nerve, the ventral vagal complex, and that creates an increase in our heart rate. And as we breathe out, we create an increase in ventral vagal activity, and therefore we create this decreasing of our heart rate. And so, anybody ever feel really stressed and then you sigh and you feel a little bit better? Anybody ever been in your car and stressed out and then you just sing, belting it out, and then it makes you feel a little bit better? Part of that reason is because we're activating that ventral vagus, right? So with this being said, all right, let's keep going. I love heart rate variability. Obviously, we have a vendor they're great. Heart rate variability, from what I've learned, is probably the best. We've looked at all these different things to look at people's level of stress in their body, right? Königsberg test and all these different things, ligament stretch response. Objectively, from what I've learned and where I'm at right now, it seems that heart rate variability is the best current method we have for assessing the stress that a person is under. So I encourage a lot of my patients to get heart Oura rings and things like that, and I love I love heart rate variability. It really tells me if what I'm doing is working. So the other thing that I've learned is that HRV is best measured first thing in the morning or while sleeping. Okay, good. All right, so it also has projections to the muscles of the face, neck, and ears. So does anybody recognize this person? Ted Kaczynski, right? So you're probably wondering, why do I have to? And interestingly enough, you went to University of Michigan. I'm wearing my University of Michigan socks. So with this being said, does anybody know why I have this picture up? So Ted Kaczynski is a perfect example of medical trauma. He was hospitalized as a very young child and basically isolated for months. And his parents said when he came back from the hospital, it was like a different person. We never had the same person again, right? And so what happened was he lost his ventral vagal complex. He no longer felt safe. So so the ventral vagus, that safety mechanism, is going to have projections to the muscles of face, neck, and ears, and especially the muscles of the upper face and head. And so when you look at people, when we are looking at people, we can tell just inherently whether or not somebody is good or bad, or they give us this feeling of safety. And if you look at people who are traumatized, you'll see they have no activation of the muscles of the upper half of their face. This is how astute clinicians start to understand what's going on with the patients, and they get feedback. And they know, when you walk into a room with somebody who's usually, bubbling and happy. And, I remember one time I had a patient of mine walk in. The guy would come in, came in once a month. I'd fix him up. He'd be great. And one day he came in, and I immediately said, "Sean, what's going on?" And he was a tech at one of the treatment centers, and he had a kid OD on him that morning, and he was trying to save him. And so, immediately, and interestingly enough, the stuff that I did on him, which was before I even learned Dr. Bandy's trauma stuff, it was a lot of the same stuff, and it was really, really, really helpful for him. So loss of ventral vagal complex is going to, number one, result in less emotional expression in the face, right? So, especially the upper half of the face. So the other thing that gets controlled by this is something called vocal prosody. And if you talk to a traumatized person, they'll have this flat affect and they don't really give you any tone. But me, I'm up here, I'm gesticulating, I'm talking with inflections. The vocal prosody is the stuff that we can do when we actually feel safe, when we have good activation of that ventral vagal complex, right? So this is the stuff that starts to get affected. And this is this is where I'm going to show you a little bit of a technique, something that I think I figured out. So it also has projections to the muscles of the ears, right? And so the muscles of the ears that the ventral vagus projects to are the tensor tympani and the stapedius muscles. And what those muscles do, is they pull the eardrum tighter to dampen out noises, especially low volume noises. And so when you think of it from like an evolutionary type, the low volume noises are typically predator noises, right? You're listening for cracking in woods and thumping down, in the woods, and it's not the vocalizations. And so when we feel safe, we can actually dampen out, we can turn off the volume of what's going on around us, those low-pitched noises, and we can listen to people, human vocalizations. We can hear people. There's a movie I used to watch, I love this movie, Lock, Stock, and Two Smoking Barrels. And there's a scene in this where this kid loses 500,000 pounds, and immediately all you hear is, and everybody's speaking in the background, and it's just he's just completely dazed from this huge hit he took. He lost complete control of that ventral vagus right there. He probably had some dorsal vagal stuff and sympathetic stuff going on as well. But when we lose that ventral vagus, we lose the ability to hear people, right? So the other thing that happens with the ventral vagus is it increases activation of the prefrontal gyrus and the temporal lobes. So what that means is when you feel not safe, you lose the ability to have a personality, to be courteous to other people, and at the same time to access your old memories and make new memories, learn from your mistakes. And so I see these kids that are coming through these treatment centers that are making stupid decisions. It's what were you thinking? I wasn't thinking, right? I mean, if you don't feel safe, if you don't have activation of the ventral vagus, it's hard for us to activate those memories and pull from that memory pool and say, I've done this before and it resulted in very, very, very bad things. Maybe I shouldn't do it again. They're just complete limbic activity where they're I want to do this, I'm going to go after it, right? So we need that suppression of our limbic system through activation of our ventral vagus and activation of our prefrontal cortex and our temporal lobes. So the sympathetic nervous system is principally controlled through our adrenal glands, but I like to think of this as mobilization of energy. We walk around, we don't have batteries on us that we have to charge up every single night because we have a lot of fuel that's just sitting in our body. And when we activate the sympathetic nervous system, we put gas in the chamber and it is ready to go. The engine starts revving, right? So I just like to think of this, to explain this to people, as releases of energy stores. So the dorsal vagus is going to originate at the dorsal vagal nucleus. It's unmyelinated. It's considered our older reptilian nucleus, and it primarily controls the subdiaphragmatic organs. So this is the digest portion, the rest and digest portion of the vagus nerve. So, like I said, it primarily controls the subdiaphragmatic organ, and that is the part of us that creates that freeze response. And so, the story I always tell people about is, so I play ice hockey, and the goalie of my ice hockey team was a Navy SEAL. He was actually on Operation Red Wing, CIA handler for the doctor that found Osama bin Laden. And we play hockey, and we go out, and afterwards we eat and hang out. And he told me about buds one day, and he was really strategically very good. So he realized very early on they picked on the people in the front of the pack and they picked on the people in the back of the pack, and he was able to keep himself in the middle of the pack. And he noticed kind of got a little bit less flack when that happened. But this one day he was teamed up in one of the diving training exercises with this one guy that nobody wanted to be teamed up with because this guy was just a mess up, and he'd always so he's underwater, he's reliant on this guy for air. And so he's not, and basically, you realize these SEALs, they practice holding their breath. I mean, they can easily hold their breath for 4 minutes. I mean, these guys, they trained to be able to hold their breath for a really long time. So he's underwater, he's waiting for this guy to get him air, and basically, the guy's messing up, he's not giving him any air, and so he's faced with either come up out of water and get disqualified, or drown. And And do you guys know what happened to him? Anybody want to guess? He crapped himself. So at that point, he had to tell the people, he said at that point he definitely brought attention to himself because they had to pull everybody out of the pool. But what happened to him then, right? So, there's a study that they talked about with, they took rats and they put them all in, they drowned them, and they found that domesticated rats, that they would last for like up to 2 hours swimming in this pool. And the wild rats, just for a few minutes they'd be in there, and then once they realized they couldn't basically make it, they'd take one deep breath and then they'd swim to the bottom of the tank, and then they would just die, right? And so what they did was they froze these rabbits really quickly. I said rats, but they were rabbits. And they thought, what happens is, the left ventricle will get so much, they thought they would get scared to death, so there would be so much sympathetic input that their heart would basically just stay contracted, so the blood flow wouldn't, would stop. Blood flow would stop. But what they found was when they looked at these rabbits' hearts, they weren't contracted; they were actually relaxed. And what these wild rabbits did was basically realize they weren't going to live, and then they checked out. They were done. That they had complete dorsal vagal activity, and their heart just blood flow stopped, and they were out. I had a friend of mine in chiropractic school. She was whitewater rafting, and the raft flipped over, and she got pinned to a rock for like 5 minutes underwater. And she said it was really peaceful. Like she didn't, it wasn't painful. She just was like ready to go. And something happened, and the current changed, and it ripped her pants off her, and it shot her to the surface, and then she lived. But she was like ready to go. I mean, and it was not a painful thing. So, so that's complete dorsal vagal activity. So I like to paint these pictures so we kind of see them. So here's the thing, and this is, so based on polyvagal theory, one can speculate that there may be gradations in reaction to life threat from total shutdown and collapse, mimicking the death feigning response of small mammals, to an immobilization of the body during which muscles lose tension and the mind dissociates from the physical body. I mean, there's accounts of people who are hunting in Asia, and they were like in the jungle and basically grabbed by a tiger. And anybody have a cat that like ever brought them a present, and then the present like ran off? You guys know what I'm talking about? So these cats, these tigers would catch these hunters, bring them to the den, they'd gash them up, and they would basically just like forget about them, and the person would be like, "I'm out of here," and then they'd make it back to safety, and they were dragged through the jungle by their head, and they have cuts all over them. And people would ask, "Was it painful?" And they would say, "No, not really. It wasn't really painful." It's like that's that dorsal vagal response. That's that death feigning response. And here's the issue: when people go through, I'm going to keep. So here's the big issue. And I added this one. I've changed the slides a little bit, but not too much. But after trauma, our brains can lose the ability to differentiate between life-threatening and non-life-threatening. This is from the Body Keeps the Score. This is huge. This is what a lot of people are going through. This is what I think everybody's going through. But a lot of the people that we see are going through this. And so let's talk about another concept here. So there's perception versus neuroception, right? So I guess it doesn't go back. So again, when we go through trauma, we lose the ability to differentiate between life-threatening and non-life-threatening, right? So there's perception. Perception is our conscious awareness of what's going on. This is our ability to, I can see that you're sitting, and I can see John Whittle just walked in. Hi. But at the same time, there's neuroception. And so neuroception is the neural process that evaluates risk in the environment without conscious awareness. Our neural pathways are constantly assessing if people or situations are safe or dangerous. If two people got into a fight in the room next door right now, we would hear this low hum turn to a and what would happen to us in here is we would lose a little bit of that ventral vagal control. Our heart rate would come up a little bit, maybe even get a little bit of activation of some adrenaline, some epinephrine, some norepinephrine, some cortisol, because we are constantly assessing what's going on in our environment, right? it was funny, look at my notes, one of my patients called it our spidey sense, right? We have a spidey sense. And so, there is something called faulty neuroception. So faulty neuroception is when we feel unsafe, but we are safe. Or we feel safe when we're unsafe. There's a lot of times where people like they walk into stupidly they're doing things like, yeah, you're in a really bad situation. You really shouldn't be walking down the street, right? Like, what do you mean? I'm perfectly safe. Like, no. Or like the people who are swimming and there's like a shark circling them and they're like, no. Like, yeah, you're not so safe. But they don't know, or they see, but you guys get the point. But the point is, a lot of people feel unsafe even though they are safe. And it's based on the fact that when we go through trauma, we lose the ability to differentiate between life-threatening and non-life-threatening. We start interpreting a lot of things as life-threatening. One of I go into this treatment center I go to, I'll go in and I will do an acupuncture day where I'll go and I'll do acupuncture to a big group. And I had this one kid, and I was going around the room, and I try to teach it. I try to use it as a chance for me to teach them. And so depending on what they want to learn about, sometimes I'm talking about like Think and Grow Rich stories. Sometimes I'm talking about gut health. Sometimes I'm talking about acupuncture stuff. Sometimes I'm talking about biomechanics, hormones. It varies every single time. But I'm going around the room and I'm just putting needles in people, and this one kid, I skipped. I was talking, I went, going around, went to the next person, and he's like, you skipped me on purpose. And he got up and he was ready to fight me. And I was like, listen, man, I didn't mean to, I was going, you can be next, you're gonna be next. And he's like, no, you skipped me on purpose. And he was like ready to fight me. I was like, so, to him, was that an appropriate or an inappropriate response, right? So a lot of people think it was inappropriate. I don't think so. I think it was an appropriate response. Everything he'd been through in his life told him that's what he had to do in order to survive at that moment, right? So we do things that are sometimes seen as by other people as inappropriate, but they're not inappropriate because we learn how to navigate the world. And now he eventually realized, he apologized to me and things like that, but the point is, and I was like, listen, you took this as like, this is what, so that's a case of faulty neuroception. So where he thought he was actually being unsafe and he acted to try to protect himself. So here's a big thing about faulty neuroception, and I really like this. Faulty neuroception might lie at the root of several psychiatric disorders, including autism, schizophrenia, anxiety disorders, depression, and reactive attachment disorder. And we can throw other things like TBIs in there. As people get older, the same thing. All this stuff, faulty, we start interpreting our surroundings as dangerous or just incorrectly, So, or sometimes not dangerous, right? And so with this being said, as we feel threatened, as we feel more threatened, we move backwards through our more phylogenetically developed autonomics. So there's something called Jacksonian dissolution. And so the idea is, there's this evolutionary kind of pathway of, first we had the dorsal vagus, then the sympathetic nervous system, and then we had our ventral vagus. And so as we feel more threatened, as we feel less safe, we start to lose activation systematically through this, right? So our first thing that we lose is our activation of our ventral vagal complex. We lose our ability to connect with people. We lose our activation of our facial muscles. We lose activation of our ability to differentiate between human vocalizations and our background noises, right? We start getting distracted by every single little squirrel, right? And what else happens? Physiologically, we start to see an increase in our heart rate, right? Not because of our sympathetic nervous system, not because of cortisol, not because of epinephrine, norepinephrine, but simply because we start to lose that ventral vagal suppression of the heart, right? And then next, we move into activation of our sympathetic nervous system. That's when we start to, basically increase our body. Our body starts getting sent a signal like, hey, you gotta get ready. You gotta get ready to move. Something's gonna happen, and you've gotta be, when it happens, you either gotta fight or you gotta run away, or you gotta something's gonna happen, so you've gotta start just getting ready, right? So you start releasing these energy units. And then next, we have activation of our dorsal vagal complex. And this is where we start to dissociate, The person might pass out. If you're, getting up to give a speech in front of a bunch of people who you love and respect, you start getting a little bit of stage fright, right? So, and this can move all the way to a death fainting response. Anybody ever been, seen somebody so stage fright they passed out? I mean, that's a dorsal vagal response, right? So, with this being said, the more traumatized you become, the more you react to your environment, and the less you can inhibit your reactions to your environment, right? So think of it this way. This is the big part here. The more you react to your environment, so the further away from feeling safe we move, the more we start picking up on everything, right? So if you're like feeling safe with friends, and you're out in a busy bar, you got your little corner, everything is safe. You can just tune everything out, and you're just, you're one-on-one with your friends. But if you're a soldier and you're standing behind a door because you think somebody's trying to kill you, and you're getting ready to go in, then you are ready. Your ears are tuned to hear a pin drop. I mean, you are just, you're ready. You're taking in everything. And versus, so when we feel safe, we lose the ability systematically to tune down what's going on around us and turn off our environment, right? So, and here's the thing, and this is a big part. When our bodies reflexively put us into a state of a survival-related state, such as shutting down, we have difficulties navigating out of it. You gotta realize, when we talk about fight, flight, and freeze, and we talk about activation of the ventral vagus, dorsal vagus, these are not things that we can control. It's not like, oh, man, I'm a little nervous. I better really get my ventral vagus working a little bit better. This is stuff that happens we can't control these things. These are automatic processes in the body.
Yes, I read the Scientific American Mind a few months ago that actually when you get into this pattern, you develop a habit pattern, and the nerve pathway is overdeveloped.
Right? Yeah, so what he said was that as we start to use this pathway of going into these states, we overdevelop this pathway, and then we get stuck in this state even more, right? I mean, yeah. So, again, when we go into shutdown states reflexively, our range of voluntary behaviors that we have is greatly reduced as well. When we feel unsafe, we can't think well. We don't make good decisions. We start being reactionary versus let me think through this problem. Let me connect with you and figure out what's going on. We start to just, become reactionary, right? And here's my, again, after trauma, our brains can lose the ability to differentiate between life-threatening and non-life-threatening. We get stuck in these patterns, and everything is unsafe. I've seen people who are, in these treatment centers, and they're they've been in these horrible situations, and then they're all stressed out, and they're giving me body postures that tell me that they're feeling unsafe. And I'm like, you know that you are safe right now. They're like, what are you talking about? Look at where I'm at. I'm like, yeah, look at where you're at. Nobody's trying to hurt you. Nobody's trying to kill you. Nobody's going to do anything but try to help you right here. But they can't see it because the experiences and the things they've done through their life have made them so, they can't feel safe. And until they, so with this being said, here's my favorite quotes from this book. As long as the mind is stuck in survival mode, loss of safety, its energy is focused on fighting off unseen enemies, which leaves no room for nurture, care, and love. And as long as the mind is defending itself from invisible assaults, our closest bonds are threatened, along with the ability to imagine, plan, play, love, learn, and pay attention to other people's needs. It's when people are traumatized, they can't see outside themselves. They can't see things from other people's perspectives. And that's important. So, this is the last concept, and we're going to do a little demo and kind of show you one thing. So, let's talk about anxiety as a maladaptive mobilization response. So, basically, what is anxiety? Anxiety is going to be your neuroception. You are taking in some sort of input that your brain is saying, hey, we're unsafe, you gotta get ready to fight or flight or freeze or something, but like, let's start with activation of the sympathetic nervous system. So what do you see with people with anxiety? Increases in heart rate, right? Sometimes you see them with a really low heart rate because they have activation of the dorsal vagus, right? I had somebody who came in the other day, a new patient, he always thinks people, you see guys that come in and think it's gonna be a disc, and he's like, yeah, I was whitewater rafting and thrown in the water for like 10 minutes, it couldn't get me out, and then he was like spelunking through caves and he got claustrophobic and he just like hasn't been right since. And I was like, okay, so not what I thought this was gonna be. All right, we're all right. So a maladaptive mobilization response is basically you're getting activation of the sympathetic system, you're getting activation, you're losing the ventral vagus enough that you start to feel unsafe and maybe disconnect from people, but you have enough ventral vagal control that you know that it would be inappropriate for you to get up and run. So basically your brain's like, you gotta move, man, go, 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 go. And your brain's like, that would be wildly inappropriate. So what do? You start sweating, you lose blood flow to your hands because you're bringing all that blood to your heart and your vital organs, and at the same time you're sitting and you're frozen, and so you get some dorsal vagal activation, some ventral vagal activation, and some sympathetic activation. So you can see how these are all parallel systems. It's not just fight or flight and freeze, it's ventral vagus, dorsal vagus, sympathetic nervous system, and they can all function simultaneously in parallel systems. So these people that are going through anxiety a lot of times, and this really resonates with a lot of people, I tell them, you seem like, the way you feel is like a track sprinter sitting at the blocks waiting for that gun to go off, but the gun's just never going. And they're just all day long, they're like, that's exactly how I feel. And again, remember, these are not voluntary things, activation of these systems are, we can't control these. A maladaptive mobilization increases mobilization of energy sources within the body without physical activity, creating the feeling of anxiety. So one of the things that Dr. Porges talked about in his book was ear covering. And so it's often observed as a coping mechanism, an observable coping mechanism in children with autism. And the interesting thing that I found, and this is kind of the part that I'm going to show you a little bit of demo, but ultimately what I use is Dr. Bandy's trauma protocol, and I use a lot of other things too, NET, and singing, vibration, we'll go over that in a second here, but ultimately, the thing that I found was really interesting was how many people felt really good when they covered their ears. I mean, it's just such a bizarre thing. And so I was thinking to myself, like, well, how exactly is this working? And so what I think is happening when we cover our ears is that when we lose ventral vagal control, we lose activation of the tensor tympani and the stapedius muscle and the muscles that tighten our eardrum that make it so that we can tune out our background noises. Now remember, 80% of the vagus nerve is sensory. So when we cover our ears, we automatically tune out those areas, those low-pitched noises. And what that does is that sensory input of safety helps to increase our ventral vagal complex activation, which in turn increases that feeling of safety. So basically, we cover our ears and we decrease our hearing of low-pitched noises, which helps us to feel safer because it helps to activate the ventral vagus through the sensory. You see this like kind of feedback loop here, or feed-forward loop really, positive feedback loop. So by covering the ears, we decrease neuroceptive input that tells us we are not safe. And notice how I'm not saying faulty neuroception, because we talk about faulty neuroception, and like my one like kind of criticism of it is I get it, but the thing is sometimes people are not safe. Like so how is it for me to say that they're in my office, they should feel safe? Well, maybe they shouldn't feel safe. Maybe it's probably faulty neuroception, but maybe they shouldn't feel safe. So, but with this being said, when we cover our ears, it seems we have increases in the ventral vagal complex, which in turn is going to decrease our dorsal vagal freeze reaction, and then decrease our sympathetic nervous system. Yes?
You notice that people, when they start to lose their hearing, one of the things they lose, the low noises, when they start to put the hearing aid in them, they reintroduce as low noises and they get nervous.
Yeah. Interesting. Yeah. I mean, that's what he said was when people lose hearing, a lot of times they'll lose their low volume noises, low pitched noises first. And so when they put those hearing aids in and they start to hear the low pitched noises again, they get really nervous. That's you lose that ventral vagal control, and you know what happens? We start reacting to our environment more, right? So here's kind of my little technique, and if anybody feeling anxious, we can kind of go over this really quickly. So, anybody cover their ears and feel good when you did it? So, anybody want to come up and So, if you're feeling a little bit anxious, a little bit nervous, what we could do is we could put a pulse ox on his finger, and but I'm just going to show you a way that you can kind of test this. And so, Dr. Bandy's protocol, he went over it last year, and I encourage you all to learn it. It's really, really good. And it's interesting because, I'll do this at these treatment centers, and I'll have times where I have people who, so you go ahead and lie on your back. My daughter, I remember my oldest daughter, Lila, would come home from preschool when she was like 2, and and she would come home at 3, and she would just be a wreck. She'd be a mess. She'd get in the door and she was crying and tantrums. And I was like, what is happening to this kid at her daycare thing? Like, she comes home and she's an absolute mess. So I would ask the teachers, like, oh, she is such an angel. She's such a great kid. She plays with everybody. I was like, what? How does this happen? So what happened, and understanding this, what I think is going on with her is she doesn't feel safe enough to allow herself to be vulnerable, so she's got to keep it all inside. So she starts to get these hits from activates the sympathetic nervous system. Maybe she gets even a little bit scared enough that she starts to activate that dorsal vagus, or she gets a little bit dissociative. But the second that she gets home, she feels safe enough that she can just let all this bottled up emotions just come out, and so she's just crying and tantrum. And I've had people that I start going through Dr. Bandy's trauma protocol on, and we start tapping points, and they just lose it. They just are completely bawling, crying. And what they say at the end of it, and I've had many, many people do this, they said, I remember one woman said, this is the first time she felt safe in 10 years. And it was like her whole life was changed after this. And when we decrease these dorsal vagal activities, it's like, people have been driving around with their emergency brake on for decades sometimes. And if we can get that dorsal vagal to just chill out, they just see the world completely different. So the way we're going to do this is you're going to test group flexors and extensors. If either are inhibited, we're going to call that a fight, flight, freeze, or an alarm state, right? And then what I'm going to do just initially is I'm going to have the patient cover their ears. And if they cover their ears and it strengthens one of these group muscle tests, then that tells me they're getting neuroceptive input that they're not safe, right? So, hopefully my computer doesn't take a dive here. So the way I do this is bring your legs together, hold them up here, push, push, push. And we can check them both, but go ahead and push it down. And so, good, toward the ground. Notice when I'm doing this, I like to give people hand signals to tell them where to push. I do that anytime I'm muscle testing. A lot of times it just helps patients to understand what you want them to do. And so, he has weakness in group leg flexors. So does that mean he needs to work on his core muscles? No, you gotta get, the core. So let's take a little step back here. One of the things that we need to understand is that, or what Dr. Bandy figured out, was that in Charles Darwin's book, The Expression of Emotions in Animals and Men, he described these body postures that we take in times of stress, right? And so when somebody's in a fight state, the flexor withdrawal pattern thing. I mean, this activation is going to start at our core muscles, and we can assess if we have activation or loss of ventral vagal control, or activation of sympathetic, or increases in dorsal vagal complex by looking at group muscle testing. And so this is kind of a window into where is your autonomic nervous system going. So go ahead and cover your ears, and let's see if this makes a difference. And it might not. So push up. So that actually made a huge difference. So so what I'll do at this point. One's got it. At least it wasn't my computer. So the reason I do this is I find this important to treat first, right? So go ahead and cover your ears. And actually, I'm going to go forward one more slide just because I want to show you the points that I treat. Again, don't forget these responses are involuntary and they have a limited range of behaviors. And you're going to have the patient hold the hands over ears. We're going to tap B&E points around 100 to 200 times at a rate of 1 tap per second. And then we're going to pulse, and then I also like to pulse the diaphragm and the stomach Chapman reflex, or excuse me, Bennett reflex, right? Neurovascular reflex. And then we're going to recheck the group. So here are our points that we're going to kind of go through. And we're just, it's okay, I'm going to tap some points. So basically, what I'm doing on what I'm doing this is I'm telling my patients what's going on. So I'll explain what they're getting input from their environment that they're not safe. And so basically you may feel like you're safe, you may say, I feel safe, but there's something going on in your environment that's alerting you to the fact that you're not safe. Whether it's the AC in the background or the color schemes that we've got in this room or whatever it is. And a lot of the points that I'll tap are going to be the GV20 on the top of the head. I'm going to tap stomach 1. Sometimes if you get even in the area of stomach 2, it's probably okay. I'm not going to go through all the other ones. Usually those are the first 2 that I'll tap. And if I don't get these, if that isn't good enough as it is, then I'll go back and I will start checking all the other points. And what you can do is therapy localized to the points, the B&E points, and see which ones show up to kind of streamline which ones you want to tap. But by and large, those are my first ones that I tap. But I'll check all of them. Triple heater 23, which is going to be over by the ear. Gallbladder 1 we're doing. Triple heater 23 we're doing. Gallbladder 1 we're doing. We're doing stomach 1 and GV20. And then sometimes small intestine 19 we'll do, which is over by the ear. And then large intestine 20, which is going to be right by the nose, right? So, at that point, bring your legs up, push up. I'd say that's not 100% perfect, but go ahead and cover your ears. Bring your legs up, push up. So that no longer helps them. So now at this point, I'm going to go through the rest of the trauma protocol, which I'm not going to do right now, but that's the point. So this is like a first step. Interestingly enough, I find that people like to cover their whole ears. Maybe there's more stuff going on than just simply putting their fingers over their ears. And thank you. You're welcome. But at this point, sometimes this will take people completely out of it and they'll get them back into, feeling safe. But more times than not, at this point, I'll go through the whole trauma protocol. But once you get people's neuroception at a point where they can recognize that they're safe, then what they end up finding is that a lot of the other treatments that people do are actually more effective. And so for me, this has been great at the treatment centers because, at this point, I don't have time to do EMDR. I don't do EMDR with them, or there's another one that they do there called like ART, which is not the active release technique. It's more the, I think it's called acute resolution of trauma. But it's very similar to EMDR. And then, to me, when I read Francine Shapiro's book on EMDR, I was like, oh, she's just doing neuro-linguistic programming. And she had some ideas about eye motion. But to me, it's like the same concept. And it all has to do with the fact that we're all kind of wired up in a certain way. And if you can kind of tap into that and balance things through that, or change the way that people see stuff, then you can be really effective. And on this note, there's a really interesting concept that also I was taught by Bandy. So there's a prevailing theory that, we all know trauma gets stored in the body, right? And when we do things like NET, NET is a perfect example. You can have somebody who's got a shoulder problem, we do NET on them, and then their shoulder pain completely goes away. And the way we do it is by, finding that emotion, having people experience it, and then, hold the points and they kind of process through these emotional issues. So it seems that with the technique that Dr. Bandy's developed, we can find the areas of the body that the trauma is stored in, treat the body, and then the things that used to bother people just don't seem to bother them like they used to. I mean, when you look at people with PTSD, successful treatment of PTSD is not forgetting what happened. It's in not reliving it. There's a quote I put in here. In The Body Keeps the Score, he says, trauma is easier than post-traumatic stress because trauma has a distinct beginning and a distinct end, whereas post-traumatic stress has no beginning and no end because people, they're not just thinking about these things that happened to them, they're actively reliving them and re-ingraining these pathways into their brain over and over again, right? So I'm going to also tell you, so basically once you do this, there's a lot of different things that we can do. You can use the Resi-Max thingy. You can do adjustments. You can sing. You can hum. You can chant. Gargle. Quantum neurology. There's a visceral manipulation. This is a breathing technique that I have people do. I like this. This is a really good. It's just a good breathing technique. And so. By clearing this response, people tend to become more present and less reactive to their environment, right? They decrease faulty neuroception, they increase their safety. After this treatment, people should feel safer, which could potentially allow them to participate in additional treatments without risk of being re-triggered. And here's kind of just a whole bunch of other body-oriented trauma therapies. And so I did the demonstration a little bit earlier, but here's the interesting thing. When we look at what we've learned right now, and we look at B&E, the tapping, what's actually happening? And so my guess is when we tap these B&E points, what we're doing is we're decreasing that vagal brake. We're taking off that emergency brake, which allows us to become less reactive to our environment, decrease the amount of cortisol and stress hormones we make, and increase our ventral vagal activity, which is going to allow us to feel safe. And interestingly enough, sometimes when I tap people, they freak out. It's only happened a handful of times, but it's happened. And I think the reason why is when people are stuck in this dorsal vagal activation, what ends up happening is the second they start feeling again, once they lose that dissociation, they just freak out and they can't deal with being here. And sometimes I treat people and they're really they have great success, but then you find these things coming back. And what ends up happening is the reason that these things are coming back is because something in their environment is re-triggering them. And what ends up happening is when we do this and we go through these protocols enough, the people become re-triggered less often, which is very, very interesting, right? Because you can't find all the triggers. You can search, and sometimes you can, but usually, it could be like the green exit sign that triggers somebody, In summary here, putting it all together, we need to stop thinking about the autonomic nervous system in terms of sympathetic versus parasympathetic, and we need to start thinking of them in ventral vagal complex, dorsal vagal complex, and sympathetic nervous systems as three parallel systems, and treating each system is equally important. And we also need to think of the Jacksonian dissolution kind of thing. So, polyvagal theory describes the physiology of how we are alerted to safety cues from our environment and the internal milieu of that drives how we interact with each other. When we go through trauma, we lose the ability to differentiate between safe and unsafe. The more unsafe we feel, the more easily we react to our environment and move towards disconnection and shutdown. And as AK doctors, we are uniquely equipped to help people unlike any other healing profession in the world. So, thank you all.